Hello, everyone. Welcome to Should You Take That Case? Expert Witness Edition. Usually, the goal of our show is to be a resource for legal professionals who pursue medical cases by sharing their experiences and insights with attorneys as our guest. But today, it is all about experts and expert witnesses, a very vital part of the litigation team. I am your host, Lisa Wade, legal nurse consultant and owner of Wade Nurse Consultants. Think of us when you have tons of medical records you need translated into normal language, easily understood by judges and juries. Visit us at wadenurseconsultants.com. But today, we are going to be interviewing Dr. Kelsey Flint from Colorado. But before we bring out Kelsey Flint, I'm going to encourage everybody who might be catching us on the replay to chime into our comment section. Give us an A in that comment section if you are an attorney, a P if you're a paralegal, but drop an E in there if you are another expert witness. We'd love to see you and to say hello. And I'd also like to thank all of you for taking precious time out of your very busy days to be with us. But now it is time to introduce our guest for today. Dr. Kelsey Flint is a licensed physician, cardiologist, and assistant professor in active clinical practice at the Rocky Mountain Regional VA Medical Center. She is triple boarded in advanced heart failure and transplant cardiology, cardiovascular disease, which is also known as general cardiology, and internal medicine. She works for both plaintiff and defense and can help attorneys determine causation, define the standard of care, and identify any breaches. Dr. Flint is also a skilled disability reviewer. In her clinical academic positions, she routinely teaches, writes, and presents in her area of clinical expertise. And now I bring to you Kelsey Flint. Hello there, Dr. Flint.
Good morning, Lisa. Thank you so much for having me on today.
Oh, I'm so glad you're here. This is going to be easy peasy, lemon squeezy. We're going to hear all about you. We I know you are board certified in 3 specialties. What does that mean to a person who isn't in medicine?
Right. So the medical training timeline is a long one. So it means that I started way back in undergrad doing the appropriate pre-med classes and then did 4 years of medical school. And from there went on to residency, which was internal medicine for me. And so that was 3 years of internal medicine, which I did at Stanford. And then internal medicine is necessary before a person goes on to cardiology fellowship. So from internal medicine, I did cardiology fellowship at the University of Colorado. And that was 3 years to become a general cardiologist. That's the cardiovascular disease board certification. And then on top of that, I did an extra year to subspecialize within cardiology as an advanced heart failure specialist. That's the advanced heart failure in transplant medicine cardiology board certification. So it ends up being a lot of paperwork to keep up with after the fact, it turns out.
Well, it sounds like you have been a very busy doctor. So, well, how about you talk to us about why you decided to go into cardiology and advanced heart failure?
Right. So cardiology has always been a field that really captured me. The heart has a lot of physiologic importance in the body, but in our culture, it also has a lot of more metaphorical importance as well. And I think that, when I was younger, like in my early 20s, I was also kind of interested in both of those. I found myself in medical school on rotations where cardiac disease was really prevalent, and the VA population where I work now has a lot of cardiac disease. That the kind of day-to-day things that some people would consider boring or mundane within cardiology, I just found so exciting every single day. And that's when I knew that perhaps this specialty was going to be for me, because of course, in any specialty or in any job, there is just the doldrum things that you do every single day that, if those are the things that you just don't see yourself doing for a whole career, then that's not going to be the thing for you. So I really found myself drawn towards the bread and butter of cardiology and decided to go into cardiology fellowship for that reason. Another reason is that cardiology for an adult cardiology has a lot of data backing what we do, meaning that some of the biggest clinical trials, especially when I was considering which specialty to go into, which at this point is getting to be about 5 to 10 years ago, the biggest clinical trials were done by cardiologists in cardiac patients. And one of the biggest centers that runs these huge clinical trials, called the DCRI, Duke Clinical Research Center, it was run by a cardiologist for the longest time. The founder was a cardiologist, and then many subsequent cardiologists took it over, even though it now runs more than just cardiac clinical trials. So I really found that exciting too, just the amount of data that we had to make sure that we were doing the right thing for our patient, as much as can ever be determined in medicine. And then also the exciting opportunity to join a field in which contributing to the research behind it had kind of a well-oiled path in front of me to follow. So that was another exciting reason that I wanted to go into cardiology.
Mhm. Well, it sounds like you have been immersed in the heart, to say the least.
Yes, I have. I have indeed. Yeah.
Well, cardiology, it is sounds like a really broad field. What types of cases do you take?
Yeah. So this is, um, it can be, I can imagine that this can be frustrating for someone who's not in my world, because there are some things that are pretty obviously belong to a cardiologist, like heart attack and atrial fibrillation and high blood pressure. People who have really tough to control blood pressure. We're one of the specialists that are the first ones that you call to get some help. Same thing with high cholesterol. For people who have cholesterol that's harder to control than just run of the mill, we're here to help. Um, but there are other conditions that kind of go across multiple specialties. One of those would be, for example, aortic dissection. So an aortic dissection is a complication usually of an aortic aneurysm. So that underlying diagnosis, aortic aneurysm, that is often made by a cardiologist because it's found on imaging that we do, such as echocardiograms, which is an ultrasound of the heart. And then when aortic aneurysms get really big, or when they have the dreaded complications of rupture or dissection, that's when a cardiothoracic surgeon really gets involved. And so you can start seeing, oh, this type of case, like, all right, we're already, counting up the specialists, where, we might have the cardiologist who diagnosed it, the cardiothoracic surgeon who would have treated it if the patient was seen soon enough. And then other cardiovascular conditions, like peripheral vascular disease is another one, where meaning blockages in the arteries that feed blood to the legs. That's something that cardiologists very frequently treat. We actually, within cardiology, there are some people who have specialized in vascular medicine in order to take care of those folks. And so a cardiologist, once again, could be the one who identifies the diagnosis, starts the treatment, and then maybe a subspecialty cardiologist treats them, or even a vascular surgeon, an interventional radiologist, et cetera. So these are tough cases to figure out sometimes. And, I am always available to help folks figure out what type of specialist they need, even if it is or isn't myself. Now, another type of condition in cardiology that I do treat a lot is called heart failure. So this is a weakening of the heart in the classic sense, where the heart is no longer able to eject as much blood out of it with each heartbeat. And this is a really prevalent condition in America. About 6 million people have it, and about 1 million are being diagnosed with it every year or so. And we have tons of treatments for it, and it still has a pretty poor prognosis in a lot of folks. So in my subspecialty of advanced heart failure, I'm qualified to take care of the sickest of the sick folks with heart failure, where in the next probably 6 to 12 months, they're either going to die of heart failure or they might need a heart replacement therapy like a transplant or an LVAD, which is also a left ventricular assist device, otherwise known as a mechanical heart. So as you can imagine, these are complex patients. Figuring out who is going to benefit from a heart replacement therapy is tricky because people need to be sick enough to warrant such a big intervention, but the rest of their body needs to be well enough to make it through. And threading that needle is always very tricky. But that's something that I really enjoy doing in my clinical practice as well. I help to identify patients who have advanced heart failure, work them up, and then work with the transplanting center to figure out if this is the type of patient who meets that window of being sick enough to really warrant it and having the rest of their body well enough to be able to go forward with it.
But it sounds like cardiology has lots and lots of layers.
It sure does, yes.
Right? And you are the one that knows how to navigate all of those layers and those twists and turns. You're the
Absolutely.
cardiologist to have. Well, let's dive into a little bit more. Now, as an academic cardiologist, you are also involved in medical education. What does that look like in your day to day?
Right. So, yeah, as you mentioned, I'm an academic cardiologist. That means that I have kind of the three pillars of academic medicine have always been clinical care, teaching, and research. And I do all three. I wanted to focus on teaching in this conversation because it really is applicable to any type of learner, whether they are someone who is a future cardiologist or not. So I help medical students, internal medicine residents. So these are, people in phases of life that I was once in, as well as cardiology fellows in multiple facets. So at the medical student level, I help teach multiple medical students, both one-on-one and in a group setting, about the basics of cardiovascular disease. So the very basics that they're going to need to know, no matter what type of physician they end up being. And teaching at the medical student level is really fun because they are so undifferentiated. They know just a little bit about a lot. Because that's the point of medical school, is that you get exposed to all kinds of things and figure out what you're going to want to go into from all of that exposure. And as I've discovered over the years, draw on that fund of knowledge when you encounter a patient who, even if a person is a dermatologist, if they know just a little bit about cardiology, they might be able to help a patient out whose rash actually reflects a heart problem. So that is really fun. And they require teaching on the most basic, on almost the most basic level, meaning they know mostly medical jargon, but they really need help understanding the pathophysiology underlying, and I really cannot make any assumptions about what they actually know about the heart, which is appropriate for their level of education. And then the next level would be the internal medicine residents who've done 4 years of medical school, and now a subset of them will go on to do cardiology, but a lot of them will do hospitalist medicine or primary care or a different subspecialty. And they also need a little broader fund of knowledge about cardiology in order to thrive in whatever specialty they end up going into. And then, of course, the cardiology fellows, I really need to make sure that I drill down into the the specialized things that they need to know, because everyone one day will be relying on them to have the answer, or at least to say, this patient has something and it is not XYZ cardiovascular conditions. So that the teaching people at all three levels is really something that I'm passionate about. I love to mentor folks as well, help them figure out how to make decisions, how to think. These are fundamental skills to any specialty within medicine. And I have found in my expert work too that that ability to teach and connect with folks is necessary as well when you're working with highly intelligent people, just like my medical students and internal medicine residents who don't have the same fund of knowledge. And that's really fun to see, to be able to teach somebody like a retaining attorney about their patient's underlying medical conditions and just like see it click, like, oh, that's the missing piece. Now I get it. And now I know where to go from here. Even if that direction, may or may not indicate that the case is going in the direction they predicted it was going in, at least, knowledge is always power.
That's wonderful. It sounds like you lead the trail of breadcrumbs from other specialties and trace them back to cardiology, so everybody knows when those links occur.
Exactly. Yep. And it's true. I do try to get them all to go into cardiology. And, it's like a 50% success rate. It's not for everybody, but I love it.
Oh, well, it has been wonderful having you with us today, sharing all of your expertise. Um, and I just want to say thank you. Thank you for coming and talking and sharing with us today.
Absolutely, Lisa. I really appreciate it. This has been such a pleasure.
Well, it's winding up for today's episode, but I would like everybody to tune in for a brand new episode of Should You Take That Case Expert Witness Edition. See you next time.
Bye.